Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? Hi, my name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 1. Welcome to the Pain is Not the Only Problem podcast. Article 1. Pain is not the only problem. Patient values. Over the years, many explanations for low back pain have been suggested throughout the research, with no consensus on the matter. Diagnosing low back pain appears to be more of a challenge to define than to treat, since no treatment self-resolves within 6 to 8 weeks in nearly 80% of cases. A modern-day diagnosis for low back pain hardly exemplifies consummate medicine. Even modern low back pain treatment strategies are unreliable. Surgical failures continue to offer unsatisfactory and unpredictable outcomes. Patient satisfaction and trust continue to decay. Without getting into the obvious statistics of occurrence, prevalence, causes, or comorbidities, let's start conservatively by making the statement. People suffer with back pain, and so the obvious thing to do as clinicians is to find the best way to treat it today at low cost. This article is part of a larger work with the same title authored by me in 2016. It may be prudent to explain that much of my research to compile the data and knowledge is recent research within the past 10 years, biased toward the more recent years. The inclusive citations inspire my arguments herein, more of an investment in the exploration into theoretical and critical thinking than towards exactitude. However, as these citations age, the validity of my findings is not influenced, since the methods and treatment plan that I propose is useful in most non-traumatic low back pain cases seen in my office to date. I know why my treatment plan works, since it is based in science. It works the same day, it is at low cost, and my patient satisfaction rate is 100% with very low recurrence. These articles intend to 1. Reevaluate the prevailing clinical practices thought to manage low back pain. 2. Submit and debate novel low back pain contributors and mechanisms. 3. Meet patient expectations and satisfaction and clinically meaningful results. And 4. Recommend a conservative non-surgical course of care to override pain instantly. And finally, 5. Restore activities of daily living and patient confidence on the first visit at low cost. Let's ask this question. Is the glass half empty or half full? Let's ask this question. Which works better, Western medicine or alternative medicine? Let's ask this question. Should I offer the surgery or not? Are we even asking the right questions? These 3 examples are either-or questions. However, there is a third answer, a non-binary answer, if you think critically. Critical thinking means that you make a highly educated examination of the data, founded on all the evidence supporting and rejecting every side of the argument. Critical thinking includes being able to understand a third possible answer, completely reframed, that proves to support the best possible patient outcomes. Number 1, whether or not the case managing doctor provides the service. Number 2, that is never based on clinical habits or automatic pilot practices. Number 3, that is never based on prejudices for or against types of care. And 4, when no other types of care offer higher patient satisfaction at 12 months. For example, epidural injection is commonly prescribed for low back pain. However, do other types of care provide better patient outcomes? Yes, all do, since patient satisfaction at 12 months is 0%. Yet epidural drugs are reflexively prescribed without regard to possible third option, critical thinking options for care, even when there is significant risk to the patient. So let's start over. Let's ask the first question again. Is the glass half empty or half full? The third answer is the glass is twice as big as it needs to be. This third answer addresses function, not a bias towards if you're a positive or a negative person, since personal opinion and character framing are not involved in the scope of the question, but rather it is implied. Clinical critical thinking should address real, not implied medicine. Asking the right medical questions, making medical decisions requires critical thinking, not medical thinking. What about the second question? Which works better, Western medicine or alternative medicine? The third answer is choose a treatment plan that offers the highest rate of patient satisfaction at 12 months, as reported by journal-published RCT articles in the past 1 to 10 years, regardless of its platform or provider. If you don't know how to find these kinds of research, ask your doctor colleagues to help you out, or learn about it on YouTube, but never settle for less than robust research. If you are a medical doctor, please connect with an orthopedic occupational chiropractic physician like me to build out your success rates of patient satisfaction. If you are a conservative alternative care doctor, please seek out alliances within the medical field, since the two disciplines have little overlap. Patient values matter more than practicing territorial medicine. Let's ask the third question again. Should I offer the surgery or not? The third answer is to prioritize patient values. Is surgery the gold standard with the least side effects, and can you prove it? Is there a lower cost treatment? And I would say, in most cases, there always is. Does the surgery return the patient back to activities of daily living and return to play faster than any other treatment? Are you offering a professional and personal money-back guarantee? This third answer is about respecting patient values over financial gain, ego, or treating from a cookbook. Nothing matters more to the patient than, is it the fastest? Is it affordable? Its effectiveness to restore ADLs and RTP quickly? And does the doctor stand behind his or her craft? Western medicine is not exempt from providing customer satisfaction. Did you even ask the patient about their values? So to be fair, let's start off on the right foot, since these articles will continue to build concept on top of concept. Pain is not the only problem. Sometimes it is the clinician's approach that is the problem. An approach based on long-time habits, personal biases, scope of practice limitations, and reimbursability, yes, that's a word, and ego. It is up to people like me, the author, and you, the clinician and researcher, to explore and expand into diverse and novel low back pain solutions. Remember, patients' low back pain gets better 80% of the time without us. Let's build on their successes. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you very much.